Good afternoon or good evening, everyone, depending on where you are in the United States. I certainly am on the West Coast, so it's still early in the afternoon here. I want to welcome you to this first of its kind ABC webinar being co-chaired by Drs. Annette Anson and Dr. Rachel Bond called Rhythm and Blues, Learning About Congenital Heart Disease. We in the ABC are committed to health, saving the lives, hearts, and minds of a diverse America. And indeed, this program, this first of a kind program, will focus on health of women and children. We have within the ABC a committee that focuses on these two potentially vulnerable populations. We hope that from this Table Talk series that you learn about pediatric congenital heart disease from these outstanding panelists that we have convened this evening. Oftentimes when we think about the ABC, or when you think about the ABC, you're often thinking about adult heart disease. But we are here to say that we are focusing on cardiovascular disease actually across the lifespan because we know that it's so critically important to focus on the health of women and to focus on the health of children. I want to congratulate the co-chairs for putting together this outstanding program tonight, and also want to have the audience be aware of another outstanding document that these co-chairs have also worked on, which is a position paper from the Association of Black Cardiologists about improving maternal health. We certainly know that this is Heart Month, and it is a month where we celebrate as well Black history. Indeed, we at the ABC know that Black history is the entire 12 months of the year, but along with the time that we celebrate, we want to highlight to you, and we're very proud of the publication in CERC Quality Outcomes about working agenda for Black women. So welcome to our program, and we hope that you learn a lot this evening. And I want to turn over the podium to Dr. Rachel Bond, who's done a spectacular job as part of the initiatives related to maternal health within the ABC and beyond. Dr. Bond.
Thank you so much, Dr. Albert, for that amazing introduction. And I welcome all of you today, particularly it is International Women and Girl in Science Day. So we're so delighted to have such a diverse group, not just from a gender perspective, but even from our own background perspective of panelists. So we're really eager to get started. With that, as Dr. Albert mentioned, I'm very fortunate to be a co-chair of the Women and Children's Committee at the Association of Black Cardiologists. And it's our commitment to making sure that we improve the quality and outcomes when it comes to cardiovascular disease or complications, starting in children and expanding that to adulthood, particularly for women. I'm honored that our paper was published yesterday in CERC Outcomes, and it really paints a very nice picture of why we need this age spectrum, this focus on all different ages, particularly starting in pediatrics, even beyond, including our congenital heart defect patients out there. So with that, I look forward to learning from the panelists as well as engaging with you all. And I do want to now hand it over to Dr. Anson. So Dr. Annette Anson is an amazing co-chair of mine. As I said, we both have the opportunity to co-chair the Women and Children's Committee. In addition to that, she wears many, many hats, but the most important for her is being a pediatric cardiologist in the state of Virginia, where she's really changing the quality of care in our diverse patient populations. So with that, Annette, Dr. Anson, I'd like to hand it over to you.
Thank you. Thank you both, Dr. Albert and Dr. Bond. I want to first welcome and thank our guests for joining us this Thursday evening. And without further ado, I want to go ahead and introduce our esteemed panel of guests in pediatric cardiology. And they include Dr. Jason Williams, who is a fourth-year fellow in advanced non-invasive cardiac imaging at Nationwide Children's Hospital. Welcome, Dr. Williams. Dr. Kayla Lopez, pediatric cardiologist and fetal cardiologist at Texas Children's Hospital. Welcome, Dr. Lopez. Dr. Abbas Zaidi, pediatric cardiologist at AI DuPont Hospital for Children. Welcome, Dr. Zaidi. Dr. Claude Beatty, Pediatric Cardiothoracic Surgeon at AI DuPont Hospital for Children. Welcome, Dr. Beatty as well. Dr. Aisha Frazier, Pediatric Cardiac Intensivist at AI DuPont Hospital for Children. Welcome, Dr. Frazier. Dr. Divyani Chowdhury, Pediatric Cardiologist and Adult Congenital Heart Specialist at Cardiology for Children and also at AI DuPont for Children. Strong contingent here. Welcome, Dr. Chowdhury. And last but certainly not least, one of my good friends and gal pals, Dr. Carissa Baker-Smith, Director of Preventive Cardiology and Pediatric Cardiologist, also at AI DuPont Hospital for Children. Welcome, Dr. Baker-Smith. So before we get started, I just want to tell you the lay of the land. What I'm going to do is give a case presentation. And once the case presentation has concluded, I'm going to turn to each of our panelists. And based on the case, they'll either show a slide presentation or answer a set of questions that I have based on the case. At the end of the case discussion, we'll then have a special topic session that will include talk on health disparities and also talk about telemedicine use in congenital heart disease. We will then at the end turn to our Q&A box where we will answer questions in that box. But I just want our audience to know at any point during the session, you may drop your questions in the Q&A box, not the chat box, where during the presentations, we'll try and answer them. And those that we don't get to, we'll pose at the very end. So let's get started. So we're going to start with the case presentation. So this is the couple, Nicole and John. Nicole and John are very excited because they just found out that they're going to be expecting their first child. So they are ecstatic. Nicole's pregnancy progresses along just fine. And at her 20-week visit with her obstetrician, her doctor mentions that she needs to go to an ultrasound center to get her anatomic fetal scan. This is a scan that checks to make sure that the baby's developing normally from head to toe. So Nicole and John make the appointment. She goes to the ultrasound center and the ultrasound technician is looking at the baby from head to toe and then sort of hovers over the heart area. Nicole and John don't know at the time, but the technician has some concerns about the baby's heart. So the technician then goes and calls one of the doctors over to come take a look at the images that she's acquired. The doctor looks at the images and then notices that there may very well be a hole in the baby's heart. She tells us to Nicole and John that she's suspecting congenital heart disease. Of course, Nicole and John are very anxious. The doctor then says she's going to refer Nicole to a fetal cardiologist. Nicole and John go home and they make the appointment with a fetal cardiologist and they're able to be seen within the week. At that appointment, the fetal cardiologist tells Nicole that, yes, in fact, the baby does have congenital heart disease known as Tetralogy Flow. Nicole and John are, of course, upset. Dr. Williams, based on this case presentation, could you please tell us the generalities of congenital heart disease and more specific Tetralogy Flow?
All right, thank you, Dr. Anson. And I will be discussing congenital heart disease and tetralogy of Flow. But before we talk about what's abnormal, let's discuss normal. So the heart is a very complex dynamic structure. It's usually the size of a baby's fist and forms just a few weeks into pregnancy. It's composed of 4 different parts, 4 chambers, 4 valves that control the direction of blood flow in the heart. Then great arteries that control where the blood goes. So one great artery pumps blood to the lungs and the other pumps blood to the body. I think I'm having some technical difficulties here. I do apologize. So this is a representation of the heart. And as you can see, the right heart collects the blood as it returns back to the heart from the body after it's delivered the oxygen to the tissues. And so this blood has lower oxygen, and that's normal for this side of the heart. And then it gets sent to the right ventricle, which is this pumping chamber, and gets pumped to the lungs where it picks up the oxygen that you and I are breathing. From there, it comes back to the left side of the heart, gets pumped to the body, the aorta, which is this large vessel that you see here. And so that's how normal works. So when one or more problems at birth affect the shape of the baby's heart or how it works, that baby is diagnosed with congenital heart disease. Congenital heart disease is the most common birth defect of all birth defects that can affect newborns. About 1 in 100 babies are born with congenital heart disease, or 40,000 births per year, and about 1 in 4 will need surgery or other procedures in the first year of life. Currently, there are about 35 different types, from very simple minor problems to very complex problems like underdeveloped pumping chambers. And the cause is mostly unknown. However, we know that 15% are traced back to genetic material that's passed down from mom or dad. There are certain syndromes like Down syndrome that have a higher likelihood of having congenital heart disease. Some viruses, such as German measles, are associated with congenital heart disease, and there are maternal and environmental factors that are less well known. Over the past several decades, there have been improved diagnoses before birth by prenatal ultrasound. However, not everyone has access to this technology. And after birth, with universal screening, all babies get their oxygen levels checked before they go home from the hospital, in addition to listening for murmurs, watching how the baby breathes, watching how the baby feeds, and looking for signs for congenital heart disease to see if it might be present. All critical congenital heart disease requires surgery. However, not all heart disease requires surgery. Some patients were able to watch over several years, and those with more critical heart disease may require early procedures, including multiple procedures over the course of their childhood. So a little bit of history about Tetralogy Flow. So the disease was actually described centuries before Dr. Flow described it, but he was a French physician that correctly correlated the cause of the blueness or the cyanosis and correlated the signs and symptoms correctly. And his work was published in 1888 about the blue disease. However, the term Tetralogy Flow was not used until 1924. So what is it? So Tetralogy Flow is the most common cyanotic heart disease, affecting about 577 out of every 1 million live births. And it's comprised of 4 different parts. 1, VSD, which is a large hole between the bottom pumping chambers. 2, overriding aorta, or the big blood vessel that sends blood to the body sitting over that hole. 3, blockage to the lung, or pulmonic stenosis. And 4, because that pumping chamber has to pump against that blockage, that ventricular pumping chamber gets very thick. And so I'll show this short video that kind of goes through what things look like. So as you can see here, this is the hole that's in between the bottom pumping chambers. This is the artery valve that sends blood out to the lungs. And as you'll see, that in Tetralogy Flow, this outflow tract to the lungs is very narrow. And so not enough blood flow comes to the right side and go to the lungs to pick up oxygen that we're all breathing. And so when that happens, that also forces blood across this hole. And so this blood that does not have full oxygen goes to the body, and that's what causes blueness in these babies, or cyanosis. And we know that this is a progressive process and usually gets worse over the course of several months, including becoming episodic, which is a problem for these children and an indication that surgery might need to happen. So this is actually a blue baby, or a cyanotic baby. And as you can see, there's a bluish discoloration to their skin. However, in darker skin babies, it's often hard to look at the skin and sometimes tell that there's a bluish discoloration. And so that's why it's important to do a full physical exam and look for signs at the gum line and at the tongue for blueness or cyanosis. So I hope that you're able to glean from this talk that it's a multidisciplinary team approach of all kinds of physicians within cardiology, including nursing staff and coordinators, to help us make the best decisions for the patients and the families. Dr. Anson?
Thank you. Dr. Williams? Dr. Lopez, as a member of the care team, what is your role as the fetal cardiologist?
Good evening. Our role as a fetal cardiologist is to be the intermediary between the OB team or the MFM team and the family to discuss with them what is the cardiac lesion that's been identified, counsel them on that cardiac lesion and a variety of different outcomes for those lesions, including surgical, catheter-based, or neither, depending on the lesion you have. But in the situation with Tetralogy Flow, we will often have discussions regarding how frequently they will be seen, what is the expectation when they go to surgery, will they need to have more than one surgery, and then discuss the need for lifelong care. So we kind of really run the full gamut when we're in the position of a fetal cardiologist, explaining kind of the landscape of the lesion that's found.
Right. And who should be referred to you, Dr. Lopez? Who should be referred for fetal echocardiograms?
There are specific lists of indications for that, for whom it should be requested for them to come see us in the fetal cardiac space. It is most common when there's an abnormal ultrasound. It is also commonly seen when they are unable to visualize the heart or certain structures of the heart, that they will send them to us. Also, individuals who have reproductive assistance are often sent to us, and individuals who have diabetes that precede their pregnancy. Those are all individuals who we see with frequency in the fetal space. Also, and then babies that have other lesions, other extracardiac lesions. That's not uncommon as well.
And how early can a fetal echocardiogram be done, Dr. Lopez?
Routinely, I'm going to answer that by saying routinely, fetal echocardiograms are done at the 21st or 22nd week of gestation of pregnancy. That's often when we see them because it will come after the 20-week ultrasound when it's been identified that there's an issue. But there are reports of individuals being able to do them as young as 12 to 14 weeks now, using transvaginal ultrasound probes that they use in the OB space. And so I think we're learning more and more now about how early can we detect congenital heart disease, but in general, routinely, it's routinely done in that 21 to 22 week space. Although often if there's a question like with twins, we will see them earlier, usually around 18 weeks or so.
Mm-hmm. And how accessible is it to see a fetal cardiologist? How's the referring process usually done?
So referral processes vary depending on where you are and the practice that you're in from an OB perspective. There are often referrals that occur from the OB that are affiliated with certain cardiac centers or fetal cardiac centers. So it often happens that way. Also, people can self-refer. So if you were referred somewhere and you're not comfortable with that diagnosis or you want to get a second opinion, people will often self-refer. And then we have individuals who come from various places as well for second opinions who are referred to us from other centers, for example, where we know that surgical care would be challenging. And so they will be referred to a city where there is more ability to undergo early surgical care, for example, in the setting of a really complex heart lesion.
Thank you so much, Dr. Lopez, for your time. Thank you. And next we have Dr. Zaidi. Dr. Zaidi is our general pediatric cardiologist. So the baby has been born. Nicole and John's baby has been born. They named him Zach. He's baby Zach. Dr. Zaidi, tell us, when did you come into the picture?
Hi, Annette. Thank you so much for having me, and thank you all for listening. I actually come into the picture pretty early on, actually. And I'm usually the primary cardiologist or the point person for the family. My role is to help the family navigate the complex system of how we take care of kids with congenital heart disease. So my first role and foremost role is to make sure the parents are educated about the diagnosis. So usually I'll have multiple conversations with the parents about what the diagnosis means and what that would look like in the long term for the baby. The other role that I play is to navigate by discussions with the surgeon on when the baby needs the surgery, I also watch the baby and follow the baby very closely during the ICU stay, and I talk to the ICU cardiologist routinely. And then my favorite part is to see the baby thrive and come back to my clinic and see them grow and become healthy individuals. That is the most rewarding part of my job. And then I also like to focus on heart healthy lifestyle for my patients when they come to clinic. So just focusing on how can they live a healthy life by eating a good, healthy diet, how important exercise is, and how important it is to feel like everything can be normal even though you have heart disease. So I do focus on that a lot. And I try to be the confidant for the family and for the patients by doing that.
That's awesome, Dr. Zaidi. Now we know with baby Zach that he was diagnosed prenatally, but are there other means or methods of diagnosing congenital heart disease postnatally after the baby's been born?
Absolutely. So every baby should get what's called a congenital heart disease screen. That screen includes checking the baby's oxygen levels, and a physician, a pediatrician generally, should listen to the baby and do a full physical exam. So babies do get picked up with congenital heart disease after they're born, and usually for specifically patients with Tetralogy Flow, they usually get picked up if they have low oxygen levels on that testing.
Thank you very much. And in a baby like baby Zach, how often would he have to see you after being sent home, assuming that he was stable? How often would he have to come see you in his office?
That's a good question. Initially, I see patients very frequently, especially right after surgery. So the usual follow-ups look like first in the first 2 weeks after they go home, then a month after, and then 3 months, 6 months, and then 12 months. But then if they're stable and things are going well, I usually will see them once a year.
And you mentioned something key, surgery. So with what baby Zach has, Tetralogy Flow, does he need surgery? And if so, when would he be referred for surgery?
Yeah, so pretty much all patients with Tetralogy Flow will need surgery at some point. And just to answer the question about timing, usually babies who are dropping their oxygen levels significantly or are turning blue, that's usually the time when you have to go in and fix their heart disease because you want the body to get the best amount of oxygen levels.
Thank you so much, Dr. Zaidi.
Thank you.
Transition nicely to our next speaker, who is Dr. Beatty, our pediatric cardiothoracic surgeon. So now we have baby Zach. He's been born, he's been seen by Dr. Zaidi, and he is being referred for surgery. Dr. Beatty, if you could just tell us from your perspective, the surgical perspective, how you would address Tetralogy Flow.
Well, thank you very much, Dr. Anson. And as Alan is putting up, I have a few slides just to go over a brief surgical overview. Again, I'm Dr. Beatty from the Nemours Center in Wilmington, Delaware. You can go to the next slide. So just as Dr. Williams has so eloquently described earlier, the basic principles of Tetralogy Flow, it's important to note that this disease occurs on a spectrum, just like all diseases. There are some folks who have Tetralogy Flow that have fairly mild obstruction, and some folks that have very severe obstruction, even to the point where portions of the outflow tract, the communication between the right heart and the lungs, doesn't even form. And obviously those discrepancies will alter the way that I'm able to approach a child with this disease process. And so those things will need to be informed based on the echocardiogram and other imaging studies to make a clear assertion as to what's going on there. We also have to be mindful that, as Dr. Williams mentioned, one of the primary features of Tetralogy Flow is that there's diminished blood flow from the right side of the heart to the lungs. And that blockage or that diminishment, that stenosis, can occur at a lot of different places. And so knowing exactly where the degree of outflow narrowing occurs will also affect the planning of the surgery. Other things that we need to be mindful of that aren't necessarily discussed previously are things like other anatomy. So the heart is a very efficient organ, and by that I mean that there is a lot of important things crammed into a very small space. And so we want to make sure that while we're going to fix one thing, we don't cause problems with something else. And the coronaries, or the blood vessels that give the heart muscle blood, those need to be very much, we must be very aware of them and stay away from them so we don't cause problems in the future. Another thing I always mention to parents, especially in this disease process, is that the vast majority of children who have tetralogy of flow and get an operation get what's called a palliation operation. That is, it's not a procedure that will necessarily cure your child, one surgery and done. The best way I can describe this is to use the example of hunger. Everybody knows what hunger is. You get hungry, you eat something, and when you eat something, your hunger pains go away. But the hamburger you eat doesn't keep you from never being hungry again. And so at some point in time, you have to do something else. And tetralogy of flow is very similar in that regard. We go to the next slide. And that's because of the goals of surgery. So as we described, there's a hole in the lower chambers, and that's something that we can close, and that's a sort of one and done procedure. However, the other goal of surgery is to provide the patient with unobstructed pulmonary blood flow. That is, we want blood to go from the right side of the heart to the lungs without any obstruction. And just using the most extreme example that I mentioned before, where sometimes those structures don't form at all and there's no connection. As a surgeon, then we have to make an artificial connection between the right side of the heart and the pulmonary blood flow system, the main pulmonary artery. The trouble is that when I take an 8-pound baby and I put an artificial tube in place, the size of the tube that's great for an 8-pound baby is not great for an 80-pound adolescent or 130-pound young adult. And so as the child grows, the tube in relative terms gets small, and so the symptoms recur. And because of that, that's why we call this a palliation procedure that almost always requires that a patient will come back later in life to have further operation to maintain that unobstructed pulmonary blood flow goal that we have. Now, some of the primary risks of the surgery include things that are not necessarily related to those 4 problems Dr. Williams mentioned about tetralogy of flow. But again, the heart has a lot of important structures in a very small space. We worry about things like the conduction system or the electrical system that tells the heart when to beat, because that electrical system is not clearly visible to our naked eye, but lies in this area where we're working. We worry about the pulmonary valve. As mentioned, there's several times where the obstruction can occur at the level of the valve. And so to remove the obstruction, we have to manipulate the valve and in some cases completely remove the valve. And so leakage is a possibility. And while it's well tolerated in the younger age, as the child grows, that pulmonary valve leakage can cause issues that require further operation in the future. There are other valves. As Dr. Williams mentioned, the heart has 4 valves, and 2 other valves are close to where we're working. And so we worry about possible issues with those valves after the operation. And then obviously the goal is to close the hole in the lower chamber and to provide a completely unobstructed outflow, but those may not be perfectly able to be ascertained in a specific operation. Next slide, please. So this is sort of like that graphic that Dr. Williams showed. It's what most parents get when they come to talk to me about tetralogy of flow, and it does give a very good example of sort of the basic physiology. There's a hole in between the lower chambers. There's some narrowing below the pulmonary valve where the circled area is. And this is what most parents come in with the perception of. As an aside, I took this from the Nemours website. It's a website called kidshealth.org that provides information not only on congenital heart disease, but on all sorts of disease processes. So it's a good place to go if you have any questions about disease processes. But if you go to the next slide, you'll see that there's a more anatomically accurate representation of what I as a surgeon would see in an operating room. And so if you can just imagine that patient is laying on the table and towards the left side of your screen is the head and the right side of the screen is the foot. It's basically the same picture you just saw, just rotated. I just want to point this out that as you can see from the top left picture, just the outside of the heart, trying to figure out where to make the incision, we have to be mindful of those coronary vessels again. So you see there are 2 annotations for 2 major vessels on the top of the heart. We also have to be mindful in our mind's eye where the valve would be, because if the level of the valve is obstructed, we need to be able to reach that from the incision. And if it's higher than the level of the valve, we may need to make an even larger incision. All those things we have to plan in advance based on what we know from the echo and from our interactions with the cardiologists like Dr. Zaidi. But if you look at the bottom right picture, even if you make the perfect incision, again, because of the efficiency of space, everything is very close to each other. And so you can see the hole between the chambers, that dark circle that separates the left side from the right side. Just behind that hole is a bulging structure. That's the aortic valve that we were describing previously. The dotted line that's highlighted is the representation of the conduction system. But as you can imagine, as a surgeon, we can't visibly see that. So we anticipate where that is. You can see that there are two graspers in this picture at the bottom holding a structure. That structure that's being held is the tricuspid valve. And so in just very short order, just trying to close the hole between the two chambers, we have to be very mindful of a lot of things. And this is even before we start to address the idea of obstruction of the right ventricular outflow tract. I show all these images not because as a parent you have to be aware of these things or be concerned with them, but just to show some of the complexity that can go into this operation. That all being said, this operation is one of the operations that is done most frequently in the United States. And if you have a good care team and a provider that you feel comfortable with, you should feel confident that you will have a very good repair, because success rates in this operation, at least for the initial stages and then subsequent stages we can discuss later, are very, very good. So Dr. Ansong, I'll return it to you now.
Thank you, Dr. Beatty, for that. We'll go back to my slide presentation. So our patient, Zach, has had a good repair, and he comes upstairs to the ICU, the intensive care unit, and he meets Dr. Aisha Frazier, who is our pediatric cardiac intensivist. Dr. Frazier, if you could tell us about the post-op management of baby Zach, who's just been repaired for his Tetralogy Flow by Dr. Beatty. But before doing so, if you could tell us about pre-op concerns, before surgery concerns that patients with Tetralogy Flow can encounter, and how you would manage that.
Thank you for the opportunity to speak during this excellent presentation. I'm going to talk about the cardiac ICU management of Tetralogy Flow. I did want to talk about reasons to come to the cardiac ICU before surgery, before you're referred by your cardiologist. If a baby is born known prenatally or postnatally with Tetralogy Flow, and the outflow going to the lungs is very narrow, then and not providing adequate blood flow to the lungs, there are babies that will need to come to the ICU to have medications to provide an additional source of blood flow through another blood vessel that's in utero that typically closes. It's called the patent ductus of arteriosus, or PDA. So they would come to the ICU for medications to keep that open, so that then we could have a conversation with our cardiac surgeons to determine timing of surgery, which would be prior to going home. Unlike with if the outflow is adequate, there are babies that go home and then are referred to surgery by their cardiologist. Another reason to come to the ICU is if they have TED spells, or these blue spells, and that's when there's dynamic closure of this blood going out the lung artery, and very blue blood, instead of being able to go to the lungs, goes across into the body. So they're very blue. And so a family member, parent or caregiver, what you want to do is call 911 because it's a surgical emergency, but you need to make sure that your baby is calm. That's going to be important. And there's a position that you could put your baby in to help to try to improve blood flow to go into the lung artery, called the knee to chest position. And once they come to the ICU, we will provide breathing and heart support while the surgeons in the operating room is getting prepared to take your baby to surgery emergently. So what I really want to focus more on is the post-operative course. And for a parent, it's very stressful and emotional to see your baby post-operatively in a condition like this. But just know that this is going to lead to a safe and successful recovery, even though there's all of these lines and tubes. And some of the tubes include a tube here that's going into the windpipe or the trachea. and it goes to a breathing machine to allow babies to have their breathing supported. There are lines that are coming out that provide kind of like an IV, but a very stable IV that will provide heart support medication, medications for pain and sedation, medications for blood pressure control, whether the blood pressure is high or low. And it is there that would be important for those kind of an IV hydration. There's also chest tubes that are coming out, and this is the bandage over the scar, but chest tubes that come and drain the fluid around the heart, because after the surgery, if there isn't a source of a pathway for fluids or blood to come out that is around the surgical area, then that can accumulate around the heart and squeeze the heart to prevent the heart from adequately pumping. So that's one reason why you would have these tubes. There's a monitoring to make sure that there's good blood flow going to the organs from the heart. There would be tubes coming out of the nose or mouth to decompress the stomach, the GI system. Hopefully Dr. Beatty would put in pacemaker wires so that if we need to temporarily provide heart rate control, either if the rate is too slow or that the normal conduction system that he mentioned or the normal pacemakers in the heart are not working properly, then we would be able to provide pacing. There could be irregular heart rhythms, whether it's too slow or too fast. And if that is the case, babies may need to be on certain medications or get pacing from those temporary pacing wires that's connected to a temporary pacing box. The course can really depend on whether you have any issues with heart rhythm. Your baby may be looking a little bit more puffy, and there might be swelling, which would be normal. And we would start a medication that would help with help with urine flow to improve the swelling. Your baby can then have the breathing tube removed and may initially require some supplemental oxygen support through a nasal cannula. But the goal overall is to have a smooth course so that your child can be recover well from surgery and be happy and healthy and ultimately go home. But the timing of how long they would be in the ICU would really depend on if there are any issues after surgery. I'm not sure if there are additional questions that you wanted me to answer, but I can address those in the Q&A after the presentation.
No, that was great, Dr. Fraser. Thank you so much for your thoroughness and telling us what the ICU course would be for a patient with Tetralogy Flow. So our patient has been under the great care of Dr. Fraser and her team and eventually goes home, sees doctors aiding the outpatient, is thriving and becomes a well functioning adult. And then they encounter Dr. Chowdhury. Dr. Chowdhury is our adult congenital heart specialist. Dr. Chowdhury, if you could go ahead through your presentation, tell us what an adult congenital patient should expect under your care.
Thank you, Annette. Thanks for having me on this webinar. So, now I'm the adult congenital cardiologist. So there are adult cardiologists who would take care of patients who take care of, like if you have a grandmother or a grandfather who needs to be I'm sorry, I have to share my screen. So I'm a pediatric cardiologist who also sees adult patients with congenital heart disease. So I'm what you call as an adult congenital cardiologist or a congenital cardiologist. So I'm not like a cardiologist that you would go to if you get a heart attack or your grandparents are seeing, or somebody has high blood pressure. So I am specialized to take care of patients who've had congenital heart disease, which means that they were born with a heart defect and now they're adults, but they still have specialized needs. So I tend to see these patients, as you say, after having a phenomenal repair from great surgeons and great pediatric cardiologists. These patients transition onto adult cardiologists by the time they're 18 or 20 years of age. There is always some need these children or these young adults would have, or adults would have. They may need some non-cardiac surgery. Having Tetralogy Flow doesn't prevent you from having an appendicitis. You may have an appendicitis. Your child may break their bones and the bones need to be fixed, or may need some other kind of non-cardiac surgery. As the patient grows, they participate in sports. You may go to college and want to play for a college team. So that would be the sports participation. You want to make career choices. You have a heart defect. Can you go participate in any kind of profession you want? So all these are like important decisions that will depend on how your heart is doing. So once you're born with these defects, you cannot get rid of them from your life. So you have to work around that to make it work for your life. Same thing, health insurance. Do I need health insurance for the rest of my life? Patients in their 20s and 30s don't really care about health insurance. What about, can I get life insurance? For women, big issue, pregnancy, right? Pregnancy, reproductive health. Will I pass this condition on to my children? Whether you're a mom or a dad who's having a family and you have Tetralogy Flow, will I pass this on to my children? What is the probability that my children will have the same problem? And a lot of my patients will ask me that, do I still have a heart murmur? So a lot of times people associate murmur with the presence of heart disease, but to us cardiologists, murmur just means a noise that we hear in the heart with our stethoscope, which directs the patient towards a cardiologist initially, but after that murmur loses its significance in the sense that we know that you have a heart defect and you'll always have a heart murmur of some sort for your life, And that's some of the simple things we try to explain to our patients. So because of the success of our congenital team, we have now more adults who have congenital heart disease than we have children, because children are up to the age of 18, and as they are surviving more and more, we are adding that population. So there is about 1.6 million people with adult congenital heart disease, much more than the children who have congenital heart disease. They're all surviving, and our various organizations, the American Heart Association, American College of Cardiology, we have put together guidelines, put together some guidelines for people to understand how to manage these patients, what their unique needs are, what they may need at times in their lives, and what can happen to these hearts. They may be prone to more arrhythmias. Dr. Beatty said they may need other heart surgeries because they had a valve that was placed. One of the fortunate things about the valve in Tetralogy Flow is it's on the right side of the heart. The right side of the heart is a low pressure system, so we don't have to put these patients on blood thinning medicines for life, unlike the left side operations where we have to do that. And then what about, is there a problem with the way the heart is functioning? Is this patient going to be able to deliver normally in a hospital when she's pregnant? Is this patient going to be able to play competitive basketball? So there is a patient with Tetralogy Flow who actually does competitive Olympic level sports. So it is possible to do all these things after you've had this heart surgery, but you do need to be consulting with your cardiologist. You need to be seeing somebody who understands your heart disease, who understands how your heart was formed and what the implications are there for your life. Annette, you can go ahead with your questions.
Thank you so much, Dr. Chowdhury. Actually, you answered a number of questions that were in our Q&A. So that's great. We're gonna move on to our special topics. We're just running a little bit behind. I think in the era of COVID has revealed to us a number of health disparities that exist. And unfortunately, congenital heart disease is not immune to those disparities. Dr. Kayla Lopez is a researcher in health disparities, and she's gonna give us a talk about the health disparities that exist in congenital heart disease. Dr. Lopez?
Thank you. I'm just pulling out my screen here. So the question is whether or not are there, disparities or health disparities or racial ethnic disparities in congenital heart disease. And unfortunately, the answer to that is yes. And so we do have data from a variety of different sources in the ICU, the outpatient realm, prenatally, et cetera, that shows us that there are differences in outcomes that go along the lines of race and ethnicity. And so this is a paper that we published looking at that between 1999 to 2017. And it showed that for congenital heart disease mortality or deaths throughout the lifespan from the time you're an infant to the time you're an adult, that men have higher mortality than women for congenital heart disease, that non-Hispanic Blacks have a higher mortality compared to non-Hispanic whites, and that goes all the way to age 35, and that Hispanics have unchanged congenital heart disease mortality compared to the decreasing mortality in non-Hispanic whites. And so the question is, why is this? Why do we have this? And there's several answers, but two of the main ones are things that we've been seeing, I think, much more recently that we've known as health disparities researchers, but that have been more publicized in the news as of recent. So systemic inequities stem from racism, and a lot of these inequities end up trickling down to the healthcare systems and the patients that we service. And so there are different levels of racism that exist: systemic, institutional, interpersonal, and internalized. And all of these together end up resulting in various ways in which people have challenges accessing various systems because of unfair policies or because of discriminatory practices, having access to quality care, or even understanding kind of referral patterns. All of those issues stem from some of these longstanding systemic inequities that we have in the United States. Furthermore, we have social determinants of health that play into this. And these are conditions in which people are born, grow, work, live, and age. And they have a wider set of forces and systems that shape their conditions in their daily life. So, you going to the doctor is not the only thing that makes you healthy. There are other things like, can you get exercise in your neighborhood? Do you have access to quality food? Do you have access to quality healthcare? And so all of these play into your eventual outcome of your health. And so it turns out that social determinants play a humongous role in outcomes for children and adults with congenital heart disease. And there was a recent paper that came out in 2020 looking at this. And if you look at all of the areas that social determinants affect congenital heart disease outcomes, the answer is it's all of them. It affects individuals in the prenatal space, in the adult congenital space. It affects the likelihood of getting a prenatal diagnosis, how likely you are to have a CHD, infant mortality, surgical outcomes. How do you do once you leave the hospital? What is your follow-up? What is your IQ after having open heart surgery? How often are you hospitalized as an adult? All of these factors all tie into social determinants of health and things aside from just having a heart condition. So this is critically important because who is it that takes care of individuals as they age? Well, we talked about fetal cardiology, we talked about pediatric cardiologist, but then like Dr. Chowdhury, we need adult congenital specialists. So these are individuals who are trained to take care of adults who are born with a heart problem. How many of those people exist? So first, let's talk about having an adult cardiologist. So if you have a general, regular adult cardiologist who is not a congenital specialist, these individuals actually are not trained to take care of congenital heart disease at all. As a matter of fact, the amount of training that they need is zero. They actually have the option of getting up to 6 hours of lecture, but the requirement for their training to take care of congenital heart disease patients is minimal. And so this ends up being an issue because if you look there on the left-hand side, the number of board-certified adult cardiologists is pretty robust at around 32,000. The number of pediatric cardiologists is somewhat robust as well, at 3,600. But the number of adult congenital specialists in the United States that are board certified is 550 total. And so that means that for every one adult congenital specialist, there are 4,500 patients. So we have a math problem in terms of a disparity in having access to care for adults with congenital heart disease. The other thing is that lots of individuals don't realize that they're supposed to be seeing special adult doctors for cardiac care. They never actually, once they leave the pediatric cardiologist, they don't know who to go to. So they just end up going to no one. And so they end up not having care. So they don't transition well between the two spaces. So there are lots of areas for disparity. The last section here, I wanted to speak about other things that affect the disparities in outcomes of congenital heart disease. So let's talk about this concept of bias. So bias is just a term that everyone has bias. It's a preference for a specific group, and it's unconscious and automatic, and it's formed by some of the experiences that you have. For example, in the United States, there's a bias for 70% of the population for white people. But if you're looking at the term implicit bias, and that's a term that we use a lot in medicine, implicit bias oftentimes is a stereotyping that influences a doctor and patient interaction. And that can come with a whole set of issues because you make a lot of assumptions about individuals because of your own biases that may not necessarily be true and oftentimes are not true. So this is why representation matters. And these are some quotes from an African-American woman who's a parent of a patient with a congenital heart disease, Dr. Tawana Nishibayashi. And she stated that for her as a parent in the ICU, that the onus is on her to actively dispel stereotypes daily in one of the most stressful and traumatic experiences that one can go through repeatedly with every hospital stay, every new fellow, attending, or medical staff that she encountered. And that racism happens in the hospital setting as it does in everyday life. Seeing someone that you and your child can relate to helps and makes you feel included. So representation is critically important, and it inspires comfort and understanding. So when we're looking at representation in pediatric cardiology, the question is, how are we doing? And the answer is not great. So if you look at all the way in the right-hand column, those are the underrepresented minority groups, that's Blacks and Hispanics and Native Americans. About 15% of all medical students fall into those categories. And then if you look at pediatric cardiology, 8% of pediatric cardiologists are from underrepresented racial and ethnic minority groups. And so we are not doing very well in terms of representation. And that doesn't help with things like implicit bias. So racial bias still does exist in the doctor's office. And I think there are several studies that demonstrate that who one's medical provider is can change patient outcomes, especially if you are from a community of color, if you're a person for whom English is not your first language, you can't communicate effectively, or if you feel like when you communicate, you're not heard, because oftentimes communities of color are often ignored in terms of their statements and their symptoms. This is also then true for other communities, including the LGBTQ community, who are often a historically marginalized and disenfranchised group. So there are lots of different ways that we can reduce these inequities, including having institutional policies to address some of these to improve outcomes for patients with congenital heart disease. At the institutional level, looking at diversity and inclusion of the staff, of the medical providers, understanding that the leadership is diverse and inclusive, retaining minority faculty, doing implicit bias training and awareness, cultural sensitivity, ensuring appropriate language services, looking at and screening for social determinants of health. And then from a systems level, certainly increasing the pipeline of individuals that go into medicine and pediatric cardiology and diversifying our subspecialty, diversifying editors and academic societies to promote some of these issues, and looking at lifelong care. Who is going to take care of these adults with congenital heart disease? We need to improve and increase that group of people, improving the transition from pediatric to adult care, and then debt forgiveness to encourage underrepresented minority representation, not just in medicine, but to enter fields like adult congenital heart disease.
Thank you, Dr. Lopez, so much for your talk. Dr. Lopez alluded to access to care being key in getting quality care. And Dr. Baker-Smith was going to talk with us a bit about the use of telemedicine in increasing access to care. So Dr. Baker-Smith, you're up.
Well, thank you for that. And I thank you for the opportunity to present today. And I'm looking for my slides here. Oh, here we are. So in these minutes that remain in the presentation, I wanted to talk about a couple of topics, just two in particular. One is one of the things that's been highlighted during the COVID-19 pandemic is that we have the opportunity to provide healthcare in not only an in-person manner, but also through telehealth. And I wanted to just introduce that technology, that idea to those who may be less familiar. Telehealth or telemedicine is the way in which we deliver care through a remote technology. It's usually through a phone or a computer. You're face-to-face with a provider, but not in person. There's no real-time physical exam and no real-time imaging that's typically performed, but it can be an extension of the in-person visit. And I highlight that because during the COVID-19 pandemic and that we're still experiencing, this desire maybe to touch base or have a communication with your child's cardiologist, but maybe not go into the doctor's office. There are some opportunities to connect with the child's cardiologist in a way that you may deem safer. And we've actually studied that at Nemours, and we'll be presenting that data soon at an upcoming national conference. But the next topic I wanted to talk about, and just briefly, is that we've talked about heart disease. One of the things as a pediatric cardiologist that I often encounter questions about the difference, congenital and acquired. The focus of this webinar is obviously on Tetralogy Flow, but I would be remiss if we didn't talk about the larger prevalent issue, which is acquired heart disease. And one does not exclude the other. You can have congenital heart disease and you can have acquired heart disease. And acquired heart disease is by far the most common and #1 killer of Americans, but certainly worldwide. One person dies every 36 seconds in the United States related to acquired heart disease. And acquired heart disease can be prevented 70% or so with healthy lifestyle and behaviors. And also there's a piece that's important, which is the combination of institutional practices, environment, neighborhood, communities, and how we our resilience and our reserve. That matters, and the life course that we take. But to look at the individual metrics that determine whether or not you can expect a healthier heart from an acquired standpoint, meaning acquired heart disease, atherosclerosis, heart attack, is not smoking, maintaining a normal body mass index, remaining physically active, obviously with the advice and recommendations of your adult congenital physician like Dr. Chowdhury, or pediatric cardiologist like Dr. Zaidi, or myself. I'm also a pediatric cardiologist, and also looking at your numbers, knowing your numbers. One of the things that I think that families are often surprised is that this process of acquired heart disease, and this is an artery that's becoming clogged, it begins in childhood. It begins at age 8. So it matters that I know that we're talking about things that are very stressful, but knowing that kids can have high cholesterol, up to a quarter, knowing kids can have diabetes, and that sometimes it's related to obesity. So don't smoke, maintain a normal weight, encourage your kids to exercise and to maintain a healthy diet, know the child's numbers, know that some conditions are genetic, meaning high cholesterol can be inherited, but remember that it begins in youth and that healthy diet, exercise, and sleep matters. Here's just a slide on how many hours of sleep each of us needs. I think we're almost always surprised how many hours we should be getting. And just to know that what begins in childhood can in fact extend into adulthood, and that includes blood pressure. So it matters that your child has their blood pressure checked, has their cholesterol checked when deemed appropriate. And let's all get healthy. Focus on meeting with your child's adult, with pediatric cardiologist or adult congenital doctor, but focusing on the heart healthy habits and factors that are important for longevity. Thank you.
Awesome job, Dr. Baker-Smith. Thank you so much. And I'm going to go back to my screen here. So I just wanted to, so that concludes our speakers, but I did want to provide our audience with a list of resources for those who may have children who are diagnosed with congenital heart disease. So you see the list here. And then also, because not only is February Heart Health Month, but it is also Black History Month, I wanted to commemorate those Black physicians in pediatric cardiology who blazed the trail for folks like me. They include Dr. Daniel Hale Williams, Dr. Vivian Thomas, Dr. Levi Watkins, Dr. Josephine Isabel Jones, Dr. Sylvia Swilley, and Dr. Brenda Armstrong, who were 3 of the first African-American females to be certified in pediatric cardiology. Dr. John Downing, one of the first to be certified in pediatric cardiology as well. Dr. George Ofori-Amanfo and Dr. Antonio Mott, who were 2 that were certified in both pediatric cardiology and ICU. and Dr. Wayne Franklin, who is one of the first African Americans to be certified in adult congenital heart disease. And I will turn it over to my co-chair, Dr. Bond.
Hi, thank you all so much for those wonderful presentations. We do have a few questions from the audience that I wanted the opportunity just to make sure that we highlighted. So one of them, which perhaps should be directed to our cardiothoracic surgeon, was when we have valve replacement, will the patient be on a blood thinner for life after their valve is actually replaced?
So that's very, and the short answer is, as Dr. mentioned, usually no. Basically speaking, when we replace a valve on the right side of the heart, which is where we're working when we're replacing the pulmonary valve, we can use a type of valve that is primarily a tissue valve, or what's called a bioprosthetic valve. And because of the fact that the pressures are low and there's generally not much in the way of turbulence at that blood valve interface, we don't have to worry about clots really forming there. So those patients typically do not need to be on anticoagulation.
Thank you so much for that answer. It's a very concise answer. Now, another question from the audience was, does the likelihood of having a cardiac lesion increase with twin pregnancy? I think any of you could actually answer this. Is there anyone in particular who would like to take that question? Perhaps Dr. Lopez, I see you unmuted yourself. Okay.
Sure, I can feel that question. You know, there are different types of twin pregnancies. There's various differences in terms of if the twins share certain features in terms of like a placenta or other things. And so for twins that are monochorionic diamniotic, it's a specific kind of pregnancy. Those individuals have a higher likelihood of having an interaction. Those twins have a higher likelihood of having an interaction, and that interaction can result in a higher likelihood of a congenital heart disease. Other than that, the only other thing that incurs a higher risk with twins is if the twin pregnancy was from an in vitro fertilization or from assisted fertility. Those tend to have a higher risk of having congenital heart disease as well.
Thank you so much. Now, for the panelists on the call, is there anything else you would like to say just to the audience before we actually go to our conclusion of today's wonderful webinar?
Just
Any
have
last words?
one comment, Rachel, to make.
Yes, of
Just
course.
one quick comment. We didn't talk about genetics for tetralogy of Flow, but there are some genetic disorders, especially some types of mutations that predispose the baby to develop congenital heart disease, and that can be passed on to the baby at least half the time. So if the mom carries that mutation, there's a 50% chance the baby can get that. And one important thing to remember, when the children were really young, so somebody who's 40 years old had tetralogy of Flow repair, they may not have looked for that mutation. But now they are 40, we have the resources. So something to look for if you have congenital heart disease, you can ask for some genetic testing, which probably was never done when you were a child. Yeah.
Thank you so much for that information. And beyond that, we actually did have a comment by Dr. Swiley, who wanted to acknowledge the fact, as this in February is Black History Month, that particularly what's relevant to Tetralogy of Flow is that we had a surgeon, the Blaylock, Dr. Blaylock, in the Blaylock tossing shunt that was created. And the surgeon wanted to acknowledge his lab assistant, who was an African-American male by the name of Vivian Thomas. And Mr. Thomas eventually did actually receive an honorary doctorate when he went to actually assist Dr. Blaylock at Johns Hopkins Hospital. So he insisted that Mr. Thomas was in all of his operations, and I can say that that definitely is ensuring that we're increasing the pipeline, a lot of what we are talking about here today. So thank you so much for that acknowledgement and for at least bringing that to our attention, Dr. Swiley. So with that, I do want to also acknowledge the fact that Dr. Anson provided a lot of resources. I know that within our comments, there was a question about providing those resource slides again. We will try to see as an organization if we're able to provide you that with your follow-up survey, the post survey that we are encouraging all to take. We also are encouraging all of you to learn a little bit more about the Association of Black Cardiologists in particular. One thing that was highlighted so nicely by Dr. Lopez is that in order to improve outcomes in these particular vulnerable populations, we do need to increase the pipeline and make medicine much more diverse. And that's exactly what we are doing at the Association of Black Cardiologists. We encourage anyone on the call who is in the medical field or has an interest to definitely consider membership, or at least consider exploring more about what we have to offer at the Association of Black Cardiologists. And beyond that, I'd like to say that although this was our first Table Talk series and it was such a huge success, I'm so excited to hear all the wonderful feedback. We have an additional series coming up in March, and really the intent of this Table Talk series is to open up to the community all of the possible disorders that you should be thinking about, ranging from childhood to even particularly in women, reproductive periods, as well as in adult women, making sure you're taking care of your health. So our next upcoming series is slated for Tuesday, March 9th at 7 p.m. Eastern. It's going to be called A Labor of Love, and we'll be highlighting a lot of multidisciplinary actions and collaborations ranging from doulas and midwives and cardiologists and obstetricians and high-risk obstetricians and faith-based communities, as well as the media, to really ensure that we improve quality of care in our moms. We know, particularly in women of color, specifically Black women, they're 3 to 4 times more likely to die during their pregnancy and the postpartum period, with heart disease being the leading cause. So we really want to take on that as an association at the Association of Black Cardiologists, and we look forward to you joining us as well. With that, I'm going to hand it back over to Dr. Anson to see if she'd like to make any further closing remarks. But thank you again for taking the time. And we do apologize for going a little bit over, but there was so much information and I definitely learned a lot.
Oh, thank you, Dr. Bond. I just want to thank all our panelists for being here. And I want to thank you, the audience, for showing up and hearing us out and commemorating Congenital Heart Disease Awareness Week. And yes, one of the attendings asked if we could do this again. I think we can. We'll just have to think about it and plan. But for the rest of you, just have a blessed week. And that concludes our program.